I'm presenting early results of the calcaneocuboid cuneiform osteotomy for Plano-Valgoid feet. The study was conducted at Bai Wadia Hospital for children. Historically, the low arch was considered a deformity, a sign of poor health, and a condition requiring treatment. Now, it is a widely accepted variant of the normal foot, as Stiley's aphorism that flexible flat foot is usual in infants, common in children, and within normal range in adults. So why would we operate on a flexible flat foot? The complaints of pain, that is persistent nagging pain, a decrease in function, deformity, difficulties in weight bearing, decreased quality of life, and even cosmesis are indications for surgery. There are surgical options that range from soft tissue surgeries, arthroeresis, arthrodesis, and reconstructive osteotomies, which include the calcaneal lengthening and the triple C osteotomy. Reconstructive osteotomies such as the calcaneal lengthening osteotomy or the Evans or the Moscow osteotomy described in 1975. The posterior calcaneus displacement osteotomy as described by Kustaganis. The plantar closing wedge osteotomy of the medial cuneiform, the cotton medial cuneiform osteotomy, the double calcaneal osteotomy, and the calcaneocuboid cuneiform osteotomy, also known as the 3C or the triple C osteotomy. This was described in 1998 by Scott and Mubarak, and they did a calcaneal medial displacement osteotomy, a cuboid lateral open wedge osteotomy, and a cuneiform medial cuneiform plantar closed wedge osteotomy. So the aim of our study was to evaluate the radiological and functional outcome of the patients operated with a calcaneocuboid cuneiform osteotomy. It was a retrospective study operated by a single surgeon with additional procedures of TA lengthening and first metatarsal phalangeal fusion performed where indicated. The preoperative and postoperative radiological assessment was done on the following 6 parameters. The radiological assessment was based on the calcaneal pitch, the Meares angle or the talo-first metatarsal angle, the talo-calcaneal angle, the talo-navicular coverage angle, and the talo-first metatarsal angle. We included patients with symptomatic flexible pes plano-valgus with between 8 to 18 years of age with a minimum follow-up of 1 year. We had 12 feet in 8 children. There were 6 males and 2 females. The average age was 11 years. There were 50% were bilateral cases. There were 2 patients who had spastic quadriplegia and 6 were idiopathic. The mean follow-up was around 15 months. 75% patients had pain, 100% patients had difficulty in weight bearing. 50% had cosmesis as one of their complaints and 25% had difficulty in wearing shoes. The surgical procedure, I'm sorry. The video is not loading. The lateral cortex of the calcaneum is osteotomized with the help of a saw, leaving the medial cortex intact, and the osteotomy is completed with the help of osteotomes. The medial slide or translation is done to assess the correction. An open wedge osteotomy of the cuboid is done. The plantar flexion closed wedge osteotomy of the medial cuneiform is then done. The wedge is flipped and inserted into the cuboid. The osteotomies are fixed with K-wires. For all patients, a post-op below-knee slab was given, which was converted to a cast. The patient was kept non-weight bearing for 6 weeks. The K-wires were removed, and the patient was kept additionally non-weight bearing for 4 weeks, and then shifted to ASFOs. We achieved a good symptomatic improvement in all patients. The post-op VAS score improved significantly. 8 feet had excellent correction, while 4 had a good correction. All the radiological parameters improved significantly. We had a normalization of the calcaneal pitch and the talo-first metatarsal angle on both AP and lateral views. There was a significant improvement in the talo-navicular coverage and the talo-calcaneal angle. We had 2 patients, 2 feet with superficial skin necrosis, which healed with dressings. So present a case example is a 10-year-old boy with bilateral idiopathic plano-valgoid foot operated with the triple C procedure, and at 1 year follow-up we can see the presence of a medial longitudinal arch on weight bearing. Similarly, a 12-year-old boy with spastic quadriplegia with bilateral plano-valgoid feet operated with the triple C procedure and the Vulpius procedure. He had a resolution of all his symptoms and a formation of the medial arch on weight bearing at 1 year. Our study is comparable with others in literature, especially those described by Scott Mubarak himself and Kim, 1998 and 2014, and the rate of complications are also comparable. The other comparable study in this group is the calcaneal lengthening osteotomy, which is the traditional as described by Mosca. However, studies, Moradella in 2012 found that the CLO had an 80.9% complications as compared to 3C. Similarly, it was also found on another comparative study that the 3C osteotomy allows for a better correction than the CLO, even in cases of severe pes plano-valgus deformity. So to conclude that the calcaneo-cuboid cuneiform osteotomy gives good radiological and functional outcomes with results comparable to those given in literature. There are a few limitations to our study, mainly the small sample size and a short follow-up. However, we are planning for a large sample size, definitely a longer follow-up, and maybe a comparative study with the previously done CLOs or a future in future planning. Thank you.